Good afternoon. My name is Matt Burnens. I am the Program Director for the Pulmonary Critical Care Fellowship, and it is my pleasure today to welcome you to Grand Rounds and to introduce our speaker, Dr. Eggert. Dr. Eggert comes to us from training, did his medical school at the University of North Carolina, his residency at the University of Florida, and his fellowship in pulmonary critical care at University of Alabama, Birmingham. He came up to Hampton Roads to start his practice and has been working with us at Sentara Medical Group in the Division of Pulmonary Critical Care. Since his initial start with us, he developed a strong interest in pulmonary vascular disease. And out of that interest, formed our Pulmonary Hypertension Clinic over at Sentara Heart Hospital. Since its inception, has gained accreditation by the Pulmonary Hypertension Association as a regional clinical center. Dr. Eggert is actively involved in numerous clinical research studies. He is a core faculty member with our fellowship program, mentors our fellows regularly and engages in research programs with them. And so it is my pleasure to introduce him today to give us a lecture on pulmonary hypertension in 2025.
Thank you, Dr. Martins. Can you hear me? Way in the back. And you did what I did, which is always sit in the back so you're out of the line of fire. And I don't know who you are, so I can't call on you, though I do have fellows here, so woe unto them. So kind of 2025, I've been doing this for about 20 years, and what's changed, what hasn't? Who below the fellow or resident level has ever heard of pulmonary hypertension? Excellent. Okay, so I'm starting in a pretty good place. Okay, so I'm going to get used to all of these new electronic devices, and I'm told they actually make things go forward. So I have no speaking relationships to disclose or relevant research relationships. So this is kind of an outline of what I'd like to talk about. You hear pulmonary hypertension used in kind of a sloppy way. You've probably heard there's several different types. You've heard it can be deadly. You've heard it can be a marker along a long pathway. Which is it? How do we talk about things? And, you know, a lot of times non-specific. Yeah, so sorry about that. Just learning this sucker. A lot of times the reason that it's difficult to diagnose before it becomes critical is specific. Presenting symptoms are in fact nonspecific. I feel short of breath. I'm tired. I don't know why. There's an essential diagnostic algorithm and confirmatory testing. The confirmatory test is not a historical artifact, and we'll talk about that in a moment. The gaps in care for these patients persist despite our long-term history of educational intervention. I'm sure you wouldn't be shocked to hear that, or maybe you would, that it has taken us, 20 years to achieve a diagnostic accuracy or diagnostic timing of about 2.5 years, which is basically what it was 20 years ago. So these people, we're not getting to them any faster. We are a little better at diagnosing them, but I'm not here to tell you that's all on you. It's on patients too. What can we do to help them? What can we do to help us? So I usually like to start this with a story because I find that this is just very helpful. So patient J kind of came in to an outside care provider about a couple of years ago with stage 3 obesity and a history of obstructive sleep apnea and some hypertension. He presented with anasarca, with pitting edema to his abdomen. He was short of breath. He was volume overloaded, wasn't taking his diuretics. Kind of hardly a surprise in this day and age. He was hypertensive and hadn't taken his meds in a year. He was given a diagnosis of acute on chronic diastolic heart failure and was started on GDMT. He was restarted on amlodipine, carvedilol, losartan. His past medical history, I'm just kind of looking at that there. Okay. His past medical history was also remarkable for, in addition to his non-compliance, his sleep apnea machine was being used for things other than sleep apnea. An echocardiogram obtained at the time, which is actually curious because usually it's not obtained this early in the diagnostic pathway, remarked on the poor right-sided, right ventricular images in terms of quality. He was called a, quote, new cardiomyopathy, despite what you could at best describe as HEF-MREF, or minimally reduced left ventricular ejection fraction at 45 to 50%. His intraventricular septum and left ventricular posterior wall were really not thickened very much. And again, there was no data on the right side of the heart except that it was dilated and dysfunctional. Well, that kind of seems kind of incongruent, right? But the best thing we did, or the best we could do, was give him guideline-directed medical therapy and send him out with more aggressive diuresis. The bariatric intervention I actually like, because that was certainly part of this problem. So I'm going to walk you through guidelines that are really recent. These things are from 2022, 2023, and 2024. So these are not things that you have to go back into the historical literature and kind of try to understand. These are things that we're using every day in our clinics and in our hospital patients and in the intensive care units. But what I want you to think about when you think about pulmonary hypertension, first, is it ever good? Except in altitude dwellers, maybe? No. In most of the things that you look at, including Kaplan-Meier curves to look at interstitial lung disease and chronic obstructive pulmonary disease, the presence of hypertension is an independent marker for worsening morbidity and mortality of the primary disease process. But what I want you to think about when you hear pH is increased pressure in the pulmonary circulation. So in the conduits from right to left. And increased resistance through the same circuit. So what does that mean? So do people die of pulmonary hypertension? Or do they die of the effect of pulmonary hypertension on the right ventricle? They die because the right ventricle fails, right? And then in what context does the right ventricular afterload worsen, right? Does it worsen in the context of somebody who's got obstructive sleep apnea and obesity hypoventilation syndrome, and therefore they are hypocapnic, or I apologize, they're hypercarbic and hypoxic, or are there other things going on? Do they have interstitial lung disease? Or do they have diseases that are more rare? So how is this defined? And this is a slide about nomenclature. Try not to fall asleep, but this really is important. When is pulmonary hypertension a signal that there is a primary diagnosis waiting to be made? Or when is pulmonary arterial hypertension a kind of bad vasculopathy in the small pulmonary arteries and arterioles? When is that a primary process with a lethal outcome to somebody who doesn't get a double lung transplant? So pH fundamentally is a hemodynamic condition where the mean pulmonary artery pressure is greater than 20. Now you're going to look at that and you're going to say, well, what does that mean? Well, first, it means you need a Swan-Ganz catheterization to accomplish the diagnosis. So no Swan, no diagnosis. No echo, no diagnosis. So for those people who have heard about, well, I hear that you can diagnose this and treat it by echo. No. Even though medications are generic, they're still expensive. And if you treat the wrong thing with pH-directed therapy, you can either cost the patient at worst, or at best, cost the patient money they don't need to spend. At worst, they land up in the emergency department in pulmonary edema, and you have to say why you didn't do appropriate testing. There have been recent changes to some of these guidelines, both the ones we talked about in 2022, 23, and 24. And there are 5 general types. And does anybody remember The Price is Right and Plinko board? Okay, where you had to drop the thing down and it came down to either 1, 2, 3, 4, or 5. And they put sometimes the prizes on the sides because those were always harder in terms of getting there. I want you to get to the side of the Plinko board, which is group 1 disease. Group 1 PH, or PAH, is a multifactorial syndromic process where there are times that it's idiopathic or heritable, and then it's associated with other things. But regardless, this is a primary vasculopathy where there are things happening in the wall of the blood vessels to include smooth artery, muscular hypertrophy, intimal fibrosis that will eventually cause such an increase in right ventricular afterload that the right ventricle fails. And the only way to fix it is either transplantation or death. Groups 2 through 5 on the Plinko board, if you think about it, so over to the right or the left, depending on which way my hand is moving, these are things that are associated with PH. And so these are your canaries in the coal mine. Group 2 disease for PH is associated with diseases of the heart, aortic stenosis, mitral regurgitation, diastolic dysfunction. And the big challenges are that sometimes the Plinko boards have two, the Plinko board splits and you've got a 2-group diagnosis. But for right now, let's keep it as group 2 disease means that there is a cardiac or cardiovascular problem. Group 3, and this one is an almost commit to memory one. So group 2 is common because heart disease is really common. Group 3 is PH associated with lung disease or diseases of hypoxia. So in here falls obstructive sleep apnea, obesity, hypoventilation syndrome. In here falls interstitial lung disease. In here falls COPD of whatever flavor. The things that are common usually include that and that. Things that are rare include idiopathic pulmonary arterial hypertension, and then pulmonary hypertension associated with pulmonary artery obstruction, which is group 4. What do you think might cause pulmonary artery obstruction that hangs around for a while? And there's actually some answers here if you know what the abbreviations mean. You all have been nodding a lot. Let's prove it. What's that? That's a great one, doctor, but that actually falls in group 1 because outside the United States, that is one of the most common causes of quote, idiopathic or heritable disease. It's not really idiopathic, but it is the same pathophysiology. And it's actually treated with the same drugs, except we also add on treatment for the schistosomiasis. But very good. But he studies this, so he likes to quiz me when I come. But anyway, it's clot, right? These are people with coagulopathies. These are people with, when you actually bother to check, they have factor V Leiden deficiency, or they have a prothrombin gene mutation. So, and they don't recanalize clot the way they should. And so they recanalize clot incompletely. They have non-laminar turbulent flow that tends to also be thrombogenic in the pulmonary arterial system. So when you get a VQ scan, which is essential for group 4 disease, you see that there are areas of non-perfusion that are ventilation perfusion that are not matched. And we can send those people for pulmonary thromboendarterectomy surgery, which is in this day and age about 80 to 90% curative. And this truly is the only type of pulmonary arterial, or the only type of pulmonary hypertension that is curable. The rest of these, whoops, pardon me, I'm so sorry. The rest of these are either it is a signal, pardon, having a bit of trouble here. There we go. Either a signal that something else is wrong, or it can't otherwise be fixed. And group 5 and other multifactorial mechanisms we're going to defer treatment or defer discussion of today. So, and the other thing I want you to see is way at the top, there's something about prevalence. When the last World Symposium met, they actually did change the criteria here such that the mean pulmonary arterial pressure criteria used to be greater than or equal to 25 millimeters of mercury. Now it's 20. So, and that sounds a little elevated, but if you've ever been in the ICU with a SWAN, what kind of PA pressures should you see roughly? And I'm looking at this little group right here without the senior fellows. So roughly, say 25 over 10. So I'm going to show you some cases where the pressures are 4 to 5 times higher. And obviously, you will recognize that the poor little right ventricle is not a pump designed to pump against that kind of workload. So again, this is groups 1, 2, 3, 4, and 5 on the Plinko board, spelled out a little more with a little more detail. And again, for Dr. Flemmer, there is, let's see, let me get closer to this because they said I could do this. This is fun. There is schistosomiasis 1.4.5. But what I also want to point out is the associated with at 1.4, there is utility about knowing associated conditions with pulmonary hypertension, because here we really shouldn't be missing the opportunity to identify these patients proactively, even though they are asymptomatic, as some of the associated connective tissue diseases, scleroderma in particular, PH has such a penetrance into that illness presentation that many societies recommend yearly echocardiographic screening despite them being asymptomatic, because the PH occurs so often in those populations that we are missing opportunities to attenuate that presentation if we don't screen. And who's that on, the patient or us? That's on us. So how does this happen? In other words, so we've started going down. So it's like we got to the right slot in the Plinko board, and now we're kind of focusing down. So a little bit of pathophysiology and just enough so you don't get nauseous with lunch. So the artery that's healthy looks like the top left schematic, where you have that everything looks good. There is no hypertrophy of the smooth muscle. The endothelial cells look fine. The external elastic and internal elastic lamina look good. First, you create an endothelial cellular environment where there's more vasoconstriction than there is vasodilation. And a lot of our therapeutics have spent time here. So what you'll hear about is nitric oxide pathway, prostacyclin pathway, and endothelin pathway. And actually, up until about 2 years ago, those 3 pathways were the summary of our armamentarium for treatment of this disease process. We had nothing else. And this goes back to the development of epoprostenol, which was the prostacyclin pathway back to 1994. So that's almost 30 years of no progress beyond understanding the vasoconstrictive environment in the endothelium. Despite research about glucose intolerance, despite research about autoimmune phenomenon with PAH, despite research in the associated conditions, trying to understand, is there something we could do with the associated conditions that would make this better? No luck so far. Now what we're just beginning to see with a class of drugs called the activin signaling pathway, we're beginning to get into what the heck is going on with this non-apoptotic pro-proliferative response you see in the small pulmonary arteries and the pulmonary arterioles, where they have this muscularization of the medial wall with this hypertrophy of smooth muscle, so that the vasoconstrictive environment, when it fires, muscles go like this. There's infiltration of the external elastic lamina. There's infiltration of inflammatory cells, which interestingly are loaded with CD20 positive B cells. And then the fact that these changes are not linear. In other words, some of the walls are open, but some of the walls are markedly constricted. And we know that in walls where you have some good flow characteristics in some places and poor flow characteristics in others, that is a wonderful situation for eddies and currents, which generates in situ thrombosis. And in patients with PAH who have gone to autopsy, there are plenty of small clots within those vascular spaces. So this is probably the best thing. This is another one of those commit to memory charts. This kind of talks about groups 1 through 5 and talks about where they are. In other words, where are the manifestations, pre-capillary, post-capillary, and then in the capillary beds. And it's very simple. It's remodeling of the pulmonary arteries and arterioles in group 1. Group 2, the backflow of blood into the pulmonary arterial system. 3, chronic lung disease causing hypoxia. 4 is diseases of pulmonary arterial obstruction. CTEPH is the most common. And group 5 is beyond the scope of our lecture, although I do get plenty of referrals for things like this. So this really kind of puts together the descriptive with the hemodynamic. And that's why I put the citation there for you, because people will define it descriptively and people will define it in terms of hemodynamics, but they won't put them together. And if you find somebody who's got, you find somebody who's got sarcoid, and you find somebody whose right ventricle looks ugly, and you find somebody who's short of breath and their exercise tolerance is worsening, it is incumbent on you to get started with a pH evaluation and then to send them to me. So Jay's story. So remember Jay, he came in with this kind of précis, and you're kind of like, what about this? So we're calling him left ventricular diastolic dysfunction, when in fact the walls of his his posterior wall of his left ventricle, his interventricular septum aren't that thick, right? I mean, if you said mild left ventricular hypertrophy, you might be right. And the one thing that you really want to know, which is how his RV is functioning, the gate affinity couldn't see anything and walked away. And you're like, gee, thanks. And especially since that he's on, well, I'm going to tell you now, he was on BiPAP for OHS and was hypercapnic. And as we all know, hypercapnia is a vasoconstrictor. And as we all know, hypoxia is a pulmonary vasoconstrictor. So there'd be no reason, right, to actually understand that more deeply. And this is, a better example of anchor bias I could not find. So why do we care? So this is the REVEAL cohort that one of our new colleagues, Dr. Raymond Benza, who is going to be our new academic chair for cardiology research, looked at this data in 2012. And this is where we were in terms of 5 and 8 year survival in 2012. So basically 1/3 of people died 3 years out from their diagnosis. Sounds like a neoplasm to me, particularly when you look at 7 years out and half the people were dead. This thing is inexorable and lethal. So again, PAH. So on the Plinko board, I'm all the way over to a arteriolar and small pulmonary arterial vasculopathy. pH everywhere else, not good either. But this is the one that's a fast mover, and it's deadly, not only because of the way it presents physiologically, but because it's underrecognized and misdiagnosed. So this is actually not a bad thing, but I'm a little apples to oranges here. So Dr. Chang and his group in American Heart in May of 22 actually showed that maybe we have bent the arc of justice towards us. So you look at this and you say, okay, 3 years in, 80% of people are surviving. Now, when you compare that to the slide previous, 3 years in, 68% of people were surviving. That's okay. But if you look here, so pulmonary arterial hypertension, this is all comers, okay? This is all comers in PAH. This is not, and if you remember, when I said the associated condition, scleroderma, which is so much a problem in our population, remember our population, who we serve in the Hampton Roads, who we serve in northeastern North Carolina. This is often a disease that people who are of color, they get blown off, they don't get correctly diagnosed. Right? So this is all comers in PAH. And here, this is just idiopathic and heritable who have overall a better track record of being diagnosed. And in fact, some of our drugs appear to work better in this cohort than they do in the connective tissue disease cohort. Okay, so that's important. So in fact, did we do as well as we think we did, which is maybe a 16 to 17% reduction? Maybe. A little better. So Jay's story. So Jay is kind of doing Jay, living their best life. on the couch, not moving very much. So comes back on GDMT, not really. But for symptoms of CHF, which were very severe and not consistent with the left ventricular ejection fraction, but was labeled just a bad historian because obviously it couldn't be the docs. I love that. October of 24, here's where you start to get into the meat of this. How many people have actually sat and looked at an echocardiogram? Oh, boo hiss. I saw what, 2 hands? All right, boo hiss. All right, so even my critical care people, you need to look at echoes. You really do. And the thing is that if I can get people who go out to the community in internal medicine to look at echocardiography, you are going to save both of us and the patient an enormous amount of time. And I'm going to talk to you a little bit about echo to look at things that this is not a bad left ventricle, but boy, this is an awful right ventricle. So again, he gets GDMT intensified for his presentation. He comes back in October, and finally we have an echo where a cardiologist said, gosh, he might need a right heart cath. And this is about 6 months before I got hold of him. So paradoxical septal motion, because the septum, if the left ventricle is a big muscular beast, the septum between the right and the left should push toward the right where the pressure is supposed to be lower, correct? Okay, because the pressure in the chamber on the left is supposed to be 120, chamber pressure on the right is supposed to be about 20. So the wall should be moving into the right, and here it's moving into the left. PA pressure estimate is 76. This thing called FAC, or fractional area change, is 13%. Usually it's supposed to be 35 or greater, but they recommended a right heart cath as a follow-up. Good for them. He was admitted again 2 months later, diuresed to AKI and hypotension, because he kept coming back in with edema to his belly button. So then he came back in April. So why did we keep missing this in this guy? The symptoms are ubiquitous and the symptoms are non-specific. They're short of breath. They don't feel good. They potentially can stand up and get dizzy. There's actually something called, and I'm going to actually, bendopnea, when they actually bend over and get short of breath. That's a big one. If they can tell you that they can't bend over and they can't tie their shoes because they're out of breath, that's worthy of note. So not orthopnea, bendopnea. But in the REVEAL cohort from 2012, and you look at the number of people, who responded to this questionnaire, the most number of patients had dyspnea on exertion and fatigue, some with chest pain from right ventricular ischemia. So things that you should look for, look for a second heart sound that's louder than a first heart sound. If you hear bum, 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 that's fine. Bum, 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 or worse, bum, brum, bum, brum, bad. If you hear a right ventricular, if you hear a gallop, or you put your hand on the chest and feel a parasternal heave, these are signs that the RV is failing. If you hear TR in systole, if you see hepatojugular reflux, and on a patient this sick, you will see it. I mean, actually, it wasn't until I got really into doing this that I started checking them on everybody, and it was really impressive. So if you go looking for these things, you will find them. And of course, ascites. I mean, something bilaudable was not exactly difficult to find in this patient. And they look like they're in shock. So we admitted him, and of course he had stopped all of his heart failure meds after his latest discharge because they made him feel bad because he was hypotensive and had AKI. 2 weeks prior to his admission, he had accelerated weight gain and swelling. His BMI was 45, so initially it was just because he was fat, right? So on physical exam, blood pressure was 100 on support. And what I mean by that is norepinephrine, high flow oxygen, and bumetanide. He was cool, he was sweaty, he was dyspneic, he was hypoxic, and generally a hot mess. He was thrombocytopenic, lactic acid. What do you think about that? BUN was 85, creatinine was 2.7, pro-BNP was 5,000 plus. So first, I mean, there's so many good questions to ask. So why is he hypersplenic? Well, kind of just asked that question wrong, but that's not unreasonable. Say it. Say it. Yeah, because you're absolutely right. Exactly. His right heart's gone, right? I mean, this is cardiogenic shock, presumably from right heart failure, although you haven't proved it yet. And he's in renal failure. But you know, in the ER, thank goodness here that actually they did a stat CTA. This was one thing that they took off my plate. No ILD. I won't tell you about GGOs in a patient whose physiology did mitigate them, but they said they didn't understand the POCUS. The LV looks fine. So while we were teeing up the ICU team to jog down with our own ultrasound machine, I wanted you to, and while we were doing that and kind of being short of breath because I'm not a small dude, we wanted to think about the kind of key diagnostic pathways. So this guy has been telling us the same thing for a long time. And this is in the European Respiratory Journal of 2024. Echo in unexplained chronic dyspnea should be near the beginning of your diagnostic algorithm. You know, medical history to get at associated conditions that may increase the likelihood of pulmonary hypertension. These are important and non-invasive things. NT-proBNP is critical. It is one of the few markers longitudinally that will allow me to track how my PH patients are doing. You know, you know, not all, but most, it's internally consistent. Get an EKG, do basic blood work, and if they constantly come back and they are still short of breath, well, they need an echo. And what I would encourage is, you guys are busy, I'm busy, but I spend all the time doing this. And what I would encourage is send them to me. Just send them to me. And I will do the sorting out of who needs the, you know, who needs the VQ. We'll get the right heart cath done here in a fashion where I can be in the cath lab. We can give them nitric oxide. And this is not something that I've usually said before. But if you believe that 1 to 2 or 3 patient care encounters with primary care and 1 to 2 specialty care encounters with pulmonologists or cardiologists are occurring in the community before the patient gets a diagnosis. And in addition, the patient is waiting 9 to 10 months to present, such that 17 months are going by before the patient actually gets a diagnosis from the time of the first symptom. And then they tend to show up like this. I think that it's probably incumbent on us to work together such that you have a bad echo in an associated condition, and that needs to come in immediately. And how do we do that? We're going to get to that in a little bit. So this is a 4-chamber view. This is a pretty 4-chamber view. I'm just going to go over this a little briefly because I talk too much. Pardon me. But you'll see here a couple of things immediately. That, you know, smaller right ventricle, thin free wall, you know, interventricular septum kind of, you know, moving toward the right ventricle, you know, that's, you know, just very nice. Here, there are several things immediately that the RA, you know, the right side to left side ratio is greater than 1. Here's a very pretty pericardial effusion. Here is the interatrial septum bowing into the left atrium. Here is a dyskinetic interventricular septum that is pushing toward the RV. And there are a number of things. And now, go forward again, there are echo findings that increase the echo likelihood of telling you it's pulmonary hypertension. One of the most important ones when you look for it is tricuspid regurgitant jet velocity. All those numbers on there, some of them are helpful, but these are the ones that are really helpful to me. TRV is crucial. We talked about the increased RV to LV ratio. And you know, if you actually use modified Bernoulli's equation, so an estimate of the TRV, so 3.5 square times 4 plus a guesstimate of what the cable pressure is, so say 8. If you're kind of getting towards 50 as your PA pressure estimate, they need to come see me, because in that circumstance, the likelihood that they have pulmonary hypertension is probably high. And remember, I just told you to square 3.5, multiply it by 4. Now, granted, somebody called it the modified Bernoulli random number generator because it's an estimate squaring itself, multiplying it by 4, and adding an estimate. But it's still not bad. So don't be afraid of this, please. It remains a grade A recommendation that if you're going to diagnose and understand pulmonary hypertension, the patient will undergo a right heart catheterization despite the pressures. Yes, I know the pressure's 100. We need to put on our big boy and girl pants and go get the numbers. Yes, there are complications. Too bad. Do it. You need to get a right heart cath to confirm the diagnosis and guide treatment decisions. This should be done in an experienced center. It lowers the complication rate, and it also makes it more likely that you're going to get a quality answer. Test your balloon if you're the one placing the catheter. It looks bad if you pop the balloon or you pop it further down in the pulmonary arterial tree than you want to do and you rupture the pulmonary artery. CT surgery tends not to like that. Check your tracings before the device comes out. If they give you a negative number, i.e. the right ventricular chamber pressure is 106/-5, that does not exist. That's like 6/0 in mathematics. There is no vacuum in the RV. There is no vacuum in the body. So please refuse that piece of garbage interpretation, and please gently ask your cardiologist, whoever they may be, are you sure it was level? Are you sure it was, please, ma'am, sir, get me some numbers I can action. And make sure the wedge is measured at end expiration. And the other thing, remember, when you're measuring a wedge, what are you actually measuring? You get this one, you get a cup of Starbucks. See, I heard some movement and some eyes flickering. What are you actually measuring? You're measuring a static column, right? So you're setting a static column through the pulmonary vasculature and assuming that there's no left-sided valvular pathology, either, mitral in particular, aortic also. You're basically getting a static column between the left ventricle and the side of the wedge. So if that static column has equal pressures at either end, you're actually getting a left ventricular end diastolic pressure, which is the real volume pressure on the other side of that. So that really means you know what the left-sided pressure is doing too. So if you don't believe your wedge, you can also have your cardiologist do a left-sided catheterization for LVEDP. Right heart cath confirms the diagnosis, calculates the PVR, and guides therapy, and measures how bad your dysfunction is. And that is a list right there of the variables that they obtain. In terms of complications for the fellows, pulmonary infarction will appear on your boards. They want you to know how to diagnose it. This is Loverly in terms of pretty close to what Jay's echo looked like. There is so much fun stuff there that's bad. There's the pericardial effusion, and you can see the tricuspid regurgitant jet that, So there's tricuspid regurgitant jet here is extreme. That was one thing we didn't see on the other side. You see here, we don't have tamponade, but we sure have a good effusion. The right ventricle is grossly enlarged. We can't even see the border of the free wall off here. This is a D-shaped left ventricle here. That left ventricle is almost empty because all the volume is on the other side. This thing responds to stress, not by, it's a small, thin-walled, it's supposed to be small and thin-walled. Its myocytes don't hypertrophy in response to stress. You put stress on that ventricle, it just dilates and dies. That's this. So Jay has right heart failure, cardiogenic shock. I bet you guys were thinking something like that, right? Well, that was enough to get us a little scared. So he was on dobutamine and norepinephrine. We added a prostanoid medication, which was rapidly titrated. We added epinephrine, vasopressin, put him on CRRT. to remove volume in the setting of AKI because he was making no urine, which makes sense because there was no transpulmonary throughput of fluid. And he asked, can I get married? His fiance had brought him in and he thought he was going to die that day. And he actually got married the following day because we thought he was going to die the following day. So some bedside teaching points as you were still in slow motion running to the ER to see the patient. This is just to emphasize again that thin-walled right ventricle is right here. It's not designed, it will not hypertrophy in response to increased load. It is simply going to dilate. The myocytes are different on the right and the left. They have different responses to pressors. Norepinephrine on the right seems to work better as an inotrope sometimes than on the left, where it generally responds as an alpha agent. Morphologically, embryologically, they split. When you initially have the cardiac tube in embryology, I bet you thought you'd never hear that again. When it invaginates like this, and there are all of a sudden two myocyte populations. So it's not supposed to, it's not designed to pump against the load of increased resistance. And it will try, but as you saw from you saw from Jay's story, at some point, its ability to generate higher pressures fails. And his was obviously failing. Again, sensitive to increases in afterload, rapid increases in afterload cause decreases in ejection fraction and dilation. And do you guys, when in your basic physiology course, did they ever show you the picture from Arthur Guyton in 1954 when he decided to take a dog and just clamp the pulmonary artery? It's worthwhile looking at. Yeah, I know it sounds awful. It does. But he took a clamp and basically where the PA systolic in the dog got to 40 to 50 millimeters of mercury, the atrial pressures and the ventricular pressures equalized, which is why people tell you in the setting of an acute pulmonary embolus that that's the farthest the right ventricle can go acutely before a patient dies of acute increase in RV afterload. So again, Jay had some time to condition his ventricle. You don't get an RV pressure of 100 acutely. It is not possible. But again, in this particular case, the right ventricle had a gross problem with supply and demand mismatch, right? The ventricle is relatively underperfused because of horrible problems with increased chamber pressure compromising epicardial vascular supply, and that is causing a state, in his case, of acute and chronic RV ischemia. So we added nitric, considered VA ECMO, but our transplant center declined him. So I hope that I've convinced you that he was misdiagnosed as HFpEF when in fact he was right heart failure and had an enormous amount of fluid to come off him. We diuresed him 80 pounds in the hospital and got him on about 4 different medications for his severe pulmonary hypertension. He's now at home on room air and awaiting a transplant. But he was one of the sickest that I have had in years who survived. So I'm going to skip. Don't know yet. Right now it's 2 lungs. The heart is still not perfect on echocardiogram. They don't know what they're going to do yet, but that's a good question. Their philosophies are different. Sometimes they'll take them in on ECMO and run them on ECMO for a couple of days before they decide to do the heart and the lungs. But his story is up in the air. And I'm having trouble getting his BMI down too, which now is no longer water, it's just fat. So we talked about the mechanisms before. We talked about, kind of the endothelial environment. We talked about vascular remodeling. In 2000, we had 2 drugs. We now have over 14 to 15 therapies. We have a lot of resources. So how did we get here? So in the next 15 minutes, because we started 2 minutes late, and I'm going to keep my time. I'm going to reclaim my time. I'm going to talk about why are we still not doing as good as we should? How did we get here so late? And I've been doing this for 20 years, and time to diagnosis is still just not what it should be. So this schematic, I want you to look at the top of it. This is a 3-year journey for most patients, and people come in a little short of breath. First, they wait 6 to 9 months to really say, gosh, I don't feel right. So they get a spirometry and an EKG, and there's nothing but this vague sense of unease. Maybe they'll start medication for asthma and COPD because some of these patients wheeze, but nothing really gets better. And it's only after another year in that all of a sudden we recognize, hey, the DLCO is low, and we get to an echo. And so care has been delayed for upwards of 2 years when a right heart cath is performed in a specialist PH center. And Sentara Norfolk General and Sentara Heart are a regional PH care center. So in this article by Small in Therapeutic Advances in Respiratory Disease, there was this really neat point-in-time survey that had 60% patients from Europe, about 30% from the US, and 13% from Japan. Most of the people surveyed were actually in a teaching and academic setting. And like I've talked about since the beginning, the first PH symptom appeared at 17 months, or the first PH symptom to diagnosis, that was a 17-month process. And the US was the worst group. Something I've emphasized throughout this is that people sit and wait at home, and they hope it'll go away. And interestingly, it was a 2-year wait for diagnosis in some of the initial National Institutes of Health surveys in the 1980s, so decades ago. So delayed presentation is compounded by misdiagnosis. On presentation, 40% of PAH patients are misdiagnosed. And obstructive lung disease, all that wheezes is not asthma. COPD, asthma, and bronchitis are 3 out of our 4 top misdiagnoses. And also, as I've said before, multiple referrals will often happen both at the primary care level as well as the specialty level before people actually catch on to the fact that this is neither an obstructive lung process nor a sleep disorder breathing process, though either could contribute to the overall presentation. De Belen in Journal of the American Heart Association, gaps in the care of pulmonary hypertension. So they actually did a simulation-based study, which was really cool. And they benchmarked it against all these new guidelines from 22 and 23 and said, okay, we're going to take a bunch of you guys who think you're really smart and we're going to index you to guidelines. Well, we did fabulously. On a scale of 0 to 100, we got as low as an 18 and as high as a 74. So we're still doing fabulously. And where PH was present, that prelim primary diagnosis was made 49% of the time. And here's the stat I love, which is compared to 2013, where the diagnosis was made correctly 47% of the time. So after another 10 years, with more medication and more education, in terms of the way we are used to delivering care in this model right now, we're still not getting anywhere. I'm still doing these talks. I'm still trying to teach, but it's not working. And I can't emphasize this enough. So, of course, they suggest this, which, Dr. Flemmer and I have had interesting conversations about, but be not afraid, my son, be not afraid. We're still, in terms of key things to work up, there were some interesting statistics in this article that basically said, if you order a 2D echo or a VQ scan, there is an increase of 100% in other words, it doubles the likelihood that you will eventually make the correct diagnosis in a shorter amount of time than you would otherwise. But the thing that I found really disturbing is for the people who even ordered the echo correctly and made the correct PH diagnosis, 30% ignored it. They didn't order a right heart cath. And they didn't refer to me or anybody else who could have sorted it out. So they just said, I don't care. Or it's HFpEF or whatever. I don't know what this is, but I'm too busy. Well, that's a dead patient. So there are patient-related things here. It's an insidious presentation. The patient doesn't know that this particular shortness of breath is alarming and they need medical help. There are comorbids here to confuse you. You treat them for OSA, they get better, but they don't get better enough. It does not resolve your problem. Same with obstructive lung disease. Patients are also stoic. We live in the South. Everybody's stoic. They can't afford the care, or there are geographic barriers such that every 10 miles away from a care center confers a increased odds of not coming to a diagnosis. And then there are mental health diagnoses that can confound your ability to interview the patient and get a good history. Provider related, we've talked to everybody and said, PH is so rare. No. PAH is rare. PH as an index of a disease that's in progress, that's common, right? COPD, bad COPD can have PH. That means we need to be doing something different. Bad ILD and PH actually may now have a treatment pathway. So for patients with connective tissue disease and IPF can be treated. IPF, connective tissue disease, UIP, and PH, they can be treated. See me. As far as the other things that are provider related, misattribution and misdiagnosis, incomplete testing, not referring to me. Oh, and I love this. Equity of access. So everybody understands here the demographic that we serve. And that's probably why we come to this area. So check this out. So the fourth pathway that we've been waiting 10 years for is something called an activin signaling pathway. And if you know anything about PH, you'll know that BMPR2 gene rearrangements are targets for our therapies. So these are the two biggest studies in the last several years. And this just floored me. So this is the phase 2, and wow, zero Black participants in placebo, 1 for low dose sotatercept, 3 for high dose sotatercept. So 4% or so, and then 4% other. So over 90% were Caucasian white, really? Okay, so, and then we come here. This is even worse. So, Black, Asian, other, and missing is just, again, we didn't care. Almost 90% were Caucasian, and better than that, associated with connective tissue disease, less than 15%, when in fact, the majority, I would say 30 to 40%, so just under the majority of patients I have in my practice are people of color with connective tissue disease. So how am I supposed to extrapolate the data here to be used in my population? Boy, did I give Merck an earful about this. They don't like me right now. So how do I use this on these people? Because everybody is telling me in meta-analyses from this year that this is the best thing since sliced bread. Now, granted, in this population, right here, it seems to be great. But there are centers that can churn out these patients at will. But I would submit that we need to do better than this. And we need not to greenwash in terms of money some of our data. I don't think this data stands up yet to being able to give these drugs freely. And there are some other issues with them, including new post-marketing, which is essentially phase 4 data about pericardial and sterile lymphatic effusions occurring in places they shouldn't be. Anyway, we rushed it to market, so there you are. Anyway, so surmounting obstacles. So if the echo and the PFTs are suggestive of elevated PA pressures in the absence of significant parenchymal disease, send them to me earlier. So in other words, don't think you are jamming up my system. I've got a good system, send them to me. You're busy. You guys are functioning incredibly in terms of how much work you have to do and the complexity of the work that you do. This is a rarer diagnosis. Send it to me. Early right heart catheterizations should be done here. We have a protocol for doing them that will facilitate rapid evaluation for transplant. And the meds can cost up to $200,000 a year or more, particularly if I have them on all 4 channels of therapy. Screen where appropriate, particularly in connective tissue populations, most notably scleroderma, where it is a yearly recommendation for both echocardiography as well as PFT performance. Target your educational offerings and consider simulation-based learning. I thought that one study of simulation-based learning benchmarked against the guidelines, I thought that was great. That was very objective, saying, okay, we kind of suck. And maintain a higher index of suspicion in the young and the elderly. Just because the elderly have comorbids doesn't mean they don't have PH. And just because the young may be overweight in this day and age doesn't mean they don't have PH. And then the phassociation.org is a 501c3 company, which is wonderful. They have incredible educational materials for providers as well as patients who are newly diagnosed. They also have community groups for patients who are on the more advanced therapies, which are more complicated logistically and may in fact be uncomfortable to use for periods of time in terms of side effects and just, some of them actually hurt to administer. So I welcome you to look at that. It's a great place to start if you're interested in the field. And this is just, again, a plea to screen in terms of systemic sclerosis and BMPR2 mutation carriers and first-degree relatives of those with familial PH. And here's one more interesting thing. So wearables. I think wearables do have a future here. People are talking about, deep learning and AI. So, if somebody says, hey, my heart flutters some when I'm trying to play volleyball and I can't jog the way I wanted because I get these flutters in my chest, that may be worth something. And I had referred earlier to data about, looking at patterns of utilization of the healthcare system actually correlating with a diagnosis of PAH. I thought that was fascinating. That work is ongoing. And so November is PAH Awareness Month. So I was off by a month. My apologies. And thank you for your time. So I have apparently 3 or 4 minutes for questions. So for those who didn't yawn too much, it is much appreciated because I always get worried when you're yawning that it's not just postprandial, it's me. So yes.
Hey, great talk. Thank you very much for all of that. As a primary care provider, I have a question about when to refer to you based on an echocardiogram finding. I'm referencing a patient in my head that I ordered an echo 6 months ago and it finally got done, yay, which might be some of the delay you're seeing.
Absolutely. I was going to say there should have been something for, system-related delays, healthcare system-related delays. That was definitely a missed opportunity.
Yeah, and he has chronic fatigue and dyspnea like most of my patients do, but he's got a dilated right atrium and right ventricular hypertrophy actually with normal pulse pressures, which was wonky. I sent him for a VQ, but now I'm thinking I'm going to send him to you and let you figure it out. But
that's fine.
When would be, I guess, if the pressures are normal on echo?
What's interesting is that he's got a dilated RA and he's got RVH. So there's something else going on, right? I mean, he, to actually have a muscular response, he had to have some increase in resistance across the circuit at some point. So the other question I would have is, have you done anything like exercise testing?
Just a stress test.
Yeah, so a stress test, but to look at the left ventricular myocardium. So 2 things that you could do. 1 is, do a walk test. 2 is to do a CPAT or cardiopulmonary exercise test. And then 3, I know exactly what I would do for that guy is I do an exercise right heart cath.
Well, he will look forward to that when he sees you in the office.
No
but if the pressures are normal and they're having symptoms, what would be the trigger to refer to?
Well, and the other thing is I'd also kind of make sure that, have you done a VQ?
I ordered one.
Okay. Yeah. So, so a VQ, and the other thing would be, looking for evidence of parenchymal lung disease. And, if you've done those things, then I think that's totally legit if he's still short. Very obese guy, small guy?
He's Norfolk moderate.
Norfolk moderate. Okay, fair enough. Fair enough. But I think that it's teasing things. I think that a dyspnea clinic locally would really well serve that. but that's not an unreasonable consult, particularly with the right-sided adaptations you've made or that the patient's made. That otherwise, I would say, let me wait for the echo. I'd still like the echo, but the fact that the right side sounds funny. But there are, and I think that, he's also somebody who's kind of, recurrently using the healthcare system too. Anybody else?
Hello.
Hello.
Thank you so much for that. I think sotatercept does whiten teeth, and there was an article about a week or two in the New England Journal looking at people with early pulmonary hypertension. But what I didn't understand is why they didn't use it for cirrhosis or HIV.
So HIV has been commonly excluded from pivotal trials for reasons that are not clear. It almost appears to be random. It almost appears to be a random thing as to whether or not they do that, particularly when the histopathobiology of HIV looks identical to IPAH. So I can't answer that. Now, the other one is much more interesting. So sotatercept causes telangiectasias. And my concern with cirrhosis, and the main concern with that is bleeding, in the same way that you'd have HHT or other things that might bleed. In addition, sotatercept can cause thrombocytopenia. And so I think that to use it in liver disease where there might already be diatheses for causing things like pulmonary EVMS, I would not use it in that setting. I think there are enough risk factors for small sites of bleeding already with that particular drug and maybe even pools of lymphatic fluid. I would hesitate to do that. And there I could see being excluded. Yeah. Sure.
Pretty much a statement.
That's excellent. That's awesome. So I thought in med school, they taught me to give fluids to a failing RV. So that's absolutely true, assuming there's no resistance across the circuit from right to left. So that's a classic RV infarct physiology, right? Where if from right to left, there's no resistance, fluid away. But here, if there's resistance from right to left in a small non-muscular ventricle that can't adapt to fluid loads, all you do is all that happens is the RV becomes a bag and stops contracting. Does that make sense? It's all in the resistance. It's all about what you can ask the RV to do in terms of work product. And if it's already got increased work product against a limited number of myocytes that aren't trained to hypertrophy in the setting of increased load, right? And then we give it more load in terms of giving it a fluid challenge, that's why it's an awful thought. Sir.
Sometimes I've seen in the literature, like for group 3 pH, where they say the pH is out of proportion. And I'm still not clear on how do you define out of proportion? Is it just based off PVR or?
Right, so far out of proportion has been defined as a pressure number. Usually a mean PA pressure of 40 to 45 is considered out of proportion to group 3 disease, but usually in the setting of COPD. COPD is basically the one area where all of the drugs that we've used have generally failed, while as you know, there is good data out of something called the INCREASE trial that patients with fibrotic lung disease may benefit from inhaled prostacyclin. So our standards there are a little lower, where our standards are higher for obstructive lung disease or emphysema, because truly there, the data that we have suggests that any use of pH-directed therapy is not helpful.
Thank you. And then I had another question, like in the acute setting, for someone who does not have a diagnosis of pH, and maybe you're suspecting cardiogenic shock or some kind of shock phenotype. In your experience, what do you think is like an early telltale sign that the initial assumption of what the shock is like
was wrong?
Yeah.
Echocardiography, baby. POCUS. I mean, it sounds like, again, patterns of utilization. 1, 2, if you do it wrong several times, or rather, patient comes in several times and we've tried this particular solution 2 or 3 times and it's been wrong, I would suggest another solution. really at some point you have to start questioning your own biases. And that sounds like, again, a great example of anchor bias, because we are so conditioned to think that people who look like this are simply diastolic heart failure, particularly with the penetrance into our heads of guideline-directed medical therapy. I mean, in a way, you could say, I'm going to blow your mind a little bit. In a way, you could say that failure to fill the left ventricle is diastolic dysfunction, right? So, could you call this a type of diastolic dysfunction? Well, yeah, I guess, but do you see what I'm saying? I mean, you can really get your thoughts wrapped around the axle of that, but this is fundamentally acute on chronic RV systolic failure. And, there are some basic things on that echo. There are multiple echo findings, in terms of the size of the right versus the left, the pericardial effusion, the bowing of the septi into the left. I mean, there are lots of things on there that should tell you that the right is failing and the left is just a bystander. All right, thanks everybody. Oh, yes.
Thanks. To kind of piggyback off what Dr. King was asking, so if someone gets echo in evaluation for dyspnea and the pulmonary pressures are normal, but there is no abnormality seen on the right side, like RV enlargement or RA dilatation, can you what would be the sensitivity to say this is highly unlikely now that there's pulmonary hypertension? Like, how confident could I feel in that regard?
Pretty good, and also looking at echocardiographic signs. I mean, if you really don't have a TR jet regurgitant velocity, and if you don't have a TR jet that's 2.8 over 2.8 or over, and you really don't have dilated right-sided chambers, and you don't have another reason for there to be that you go through and you can find that there's a pulmonary vasoconstricting influence, and they don't have any other evidence for an associated condition, you start to really check off things where the right could be involved. And I think at some point you have to go with the weight of the evidence. Yeah. Thanks, everybody.